And we've got some really wonderful questions from our terrific audience. And so let me just, is this a good point to throw some of these out? Okay, so one of the questions that's been asked is, you talked about the chronic pain not being an emergency, but if someone runs out of their medications, how soon do you need to start worrying about withdrawal symptoms? So if they run out on a Friday and no one's available really, what should people do?
Yeah, so a couple of things to keep in mind is, one is to think about the dose that they're on.
Yeah.
If patients are on lower than 30 milligrams or less of morphine or morphine equivalents a day, they're unlikely to develop withdrawal programs, withdrawal symptoms. So, for example, people who are in methadone maintenance programs, 30 milligrams of methadone is enough to keep them out of withdrawal. So even if they're taking high doses, they don't necessarily need to keep taking high doses to stay to avoid withdrawal symptoms. The second thing to remember is that while opioid withdrawal can be very uncomfortable, it's not life-threatening or medically dangerous, as is in contrast withdrawal from alcohol or benzodiazepines. One strategy that I use in clinic is to prescribe opioids 28 days at a time rather than 30 days at a time. That keeps me from ever running into having to do refills on the weekends and avoiding that situation. Another scenario is to sort of ask the patient, how much opioid do you have left, how many pills do you have left, and if they can take, if they have, often they'll have a stockpile, and if they're taking a small number a day, that can be enough to keep them out of withdrawal symptoms.
Oh, good. So you can have them stretch it out then for a few days. Okay. We've got another question here. So the audience is asking us, what do you do with the patient who comes in and says, gosh, I've tried every other medication under the sun, physical, and every other therapy and device, but the only thing that really works for me is these opiates. And Dr. Henry, I really need some today.
Yeah, so I guess I sort of take that, you take an individual patient approach and feel like, you want to review their medical history. I used to work at the VA, so we got patients who, I saw patients who had been through the gamut of everything. And you kind of make a risk assessment. One thing that, one clinic policy that I have that I know is often useful is to say, I typically don't prescribe opioids on the first visit for new patients. So that gives me time to take a thorough history and set that as a clinic policy and expectation so that I have enough time to do a full and accurate risk assessment. If they, so you want to see what other pain management strategies they've been doing. If they're on high-dose opioids, like more than 100 milligrams of morphine a day, I make it very clear to them that we have to taper down to a lower dose before I'll discuss anything else. And if there is if I'm worried that the risk outweighs the benefit, I'll either tell them that while I'm committed to helping them manage their pain, I think that it's important that we have to taper down the opioids because the risk outweighs the benefit. Or if they're very insistent, I'll often refer them to a pain specialist for further evaluation.
Gosh, it sounds like you're enough of a specialist for most of us. The audience has been asking whether or not this COPES program is free. Yes,
it's free, and it is also modular, so you can do part of it and then come back at a different day and finish the rest of it. It's available both at the website there on the slides, and also there's a link in the California Medical Board's website if you go under CME for pain management.
Oh, and so you mentioned CME is available for this course?
So yes, there is CME available for the online full COPE-REMS course. And there's also, that's separate from the CME for today's broadcast.
Okay. And tell me a little bit about when you decide, when you've reached your limit and you decide to refer onward, what general guidelines should physicians be using in when to refer up?
Yeah, so I think...
Or further.
It depends on, the resources and the pain specialists that you have in your area.
Okay.
One situation in which I refer relatively quickly is when I have a diagnostic question. Is there an unusual pain scenario that may be at play, for example, complex regional pain syndrome or what used to be called reflex sympathetic dystrophy, or there may be the patient may have, for example, severe knee arthritis and may benefit from evaluation for joint replacement. So I'll generally refer in those situations. I'll often tend to refer if the patient is already chronically disabled at baseline, and so they need a more comprehensive management strategy, for example, a quadriplegic patient or something like that. If the patient is clearly a high-risk patient with history of substance abuse and someone who has an established chronic pain diagnosis, I typically find that I'm going to need to do the work of tapering them off opioids, regardless of whether they go to a pain specialist or not.
We have another very interesting question about the use of opiates in pregnancy. Do you have any advice for our audience in that regard, or how to manage severe pain in pregnancy?
Sure. So I believe opioids technically are a class C medication in pregnancy, so there's not formal evidence for their safety in pregnancy. However, they are commonly used by OBGYNs. I would generally refer a pregnant patient to OBGYN, and if they have, sort of uncomplicated chronic pain. If there is a patient who is on long-term opioid therapy, or if they have a history of opioid dependence, or are taking methadone for a history of addiction, those patients are high-risk pregnancy patients, and they need to be referred to probably a high-risk pregnancy person early on, because their children or the infants are at risk of neonatal abstinence syndrome after birth.
And what is that?
So that's basically it's opioid withdrawal symptoms from a newborn baby that occur naturally when the mother is taking long-term opioids or methadone or heroin in addiction patients, and so the baby basically develops being dependent on opioids, and so gets severe withdrawal symptoms after
terrible.
birth.
Yeah. The audience is also asking, when you've mentioned several times that when someone comes in on high-dose opiates, usually over 100 milligrams per day, that you try to taper them to a safer dose. Like, what would you consider a safe goal to try to reach?
So different chronic pain guidelines have different thresholds, but I think the more recent chronic pain guidelines have established probably 100 milligrams of morphine a day as a threshold of something that you shouldn't go above. So, for example, if I have a patient who comes in taking 150 milligrams of morphine a day, I would want to taper them at least to something like 75 milligrams of morphine. And once they're at that lower dose, then I can feel comfortable that while long-term opioids may not be the best treatment for them, I'm not putting them at undue risk of overdose or death due to my own prescribing practices.
Okay. You mentioned also something about a ballot initiative for California regarding the prescribing program?
Sure, yes. I don't know, for our California audience, there is a statewide ballot initiative that's going to come to a vote sometime this fall. I don't know all the details of the initiative, but one of the stipulations is that it would require prescribers to check the prescription drug monitoring program in California, which is called CURES, before initiating treatment of Schedule II prescriptions, of Schedule II or Schedule III opioids.
One of our audience members has asked a question that really talks about our responsibility when you suspect someone is diverting. As physicians, do we have a responsibility to report criminal behavior?
Yeah, so that's a good question, and there's some controversy and disagreement among experts on this question. My typical approach is, if I have a patient who has clear evidence of criminal behavior, such as forging prescriptions, stealing prescriptions, then I'll notify the police.
Oh, you will?
Yes, but that's extremely rare. It's rare that in my practice, that we have that type of clear evidence. And more often than not, there's circumstantial evidence such as unusual results on a urine drug screen, where the patient is being prescribed a medication but it doesn't show up in their system. In those situations, unless, as I said, there's explicit evidence of criminal behavior, I typically just talk to the patient and tell them that we need to discontinue opioid therapy for their safety.
Wonderful. Well.